Okay, so today's lecture is going to focus on some of the treatment options that exist for Parkinson's disease. Here's the learning objectives. And I want you to understand that Parkinson's disease basically affects about 1 million people or so in the US. And of course, it's a movement disorder, and that involves degeneration of neurons within the nigrostriatal pathway. There is no cure, unfortunately, for this disease, and all the therapies for Parkinson's disease really get at treating the symptoms or the motor disturbances that emerge clinically. It's not really a loss of dopamine neurons that causes PD symptoms, but rather the decrease in dopamine within the striatum that's responsible for the motor symptom deficit. The drugs that are used to treat PD all aim at restoring depleted dopamine levels, or activity within the nigrostriatal pathway. Remember, there's dopamine receptor expression within the periphery, including the gut and the renal system, leading to peripheral symptoms of Parkinson's. Dopamine is a catecholamine. Also, there's some affinity to beta-1 and beta-2 receptors because dopamine it gets turned into norepinephrine. Keep this in mind as we talk about the therapies used for Parkinson's, and it'll help you understand some of the peripheral side effects that are associated with therapy. And we did talk about dopamine receptors within the gut. We had mentioned metoclopramide, basically for reducing some of the GI motility issues. We also talked about using metoclopramide with chemotherapy or in post-surgical preparations. We had also talked about the renal expression of dopamine. We talked about dobutamine as a rescue for renal perfusion in patients that experiences acute traumatic blood loss due to stabbing or gunshot wound. And so there's 3 major drug classes that can be used to treat Parkinson's disease that take place in terms of dopamine therapy. So we can look at replacing dopamine. We can use indirect acting agonists, and we can also employ direct acting agonists. So this is kind of a nice schematic for dopamine synthesis. So remember, of course, tyrosine hydroxylase is the rate-limiting step in the synthesis of catecholamines. Therefore, we can't really give tyrosine to patients because the synthesis of dopamine really won't improve. We can't give dopamine because it will not cross the blood-brain barrier, ironically, and instead will have peripheral side effects related to increased dopamine levels. So therefore, by giving the immediate precursor to dopamine, levodopa, we can increase the concentration of dopamine within the CNS. The problem with just giving levodopa is that the aromatic amino acid decarboxylase enzyme, abbreviated AAAD, is found everywhere and can biotransform levodopa into dopamine in the periphery as well as in the CNS. Because of this metabolism, only 10 to 15% of the administered dose of levodopa becomes bioavailable after oral delivery. And so that's the reason why this formulation called carbidopa was developed. So carbidopa is an aromatic amino acid decarboxylase inhibitor, or AAAD inhibitor, and it prevents the peripheral metabolism of L-DOPA to dopamine, and thereby reducing the side effects of increased dopamine in the body, such as nausea and vomiting and orthostatic hypotension. You see increasing bioavailability as well as the amount that can cross into the brain. Carbidopa cannot cross the blood-brain barrier, and it won't affect the concentration or the conversion of CNS levodopa to dopamine. Levodopa is particularly effective for the management of bradykinetic symptoms of Parkinson's disease. And the main side effect, of course, are dyskinesias. So I like this summary table basically emphasizing the importance of carbidopa and its ability to kind of restrict some of the more undesirable side effects. So prior to levodopa's formulation with carbidopa, patients would have side effects that would include hypotension, vomiting, basically triggering the area postrema, and GI disturbances. With the combination of carbidopa plus levodopa, so one pill with both drugs inside of it, you see a reduction in some of the peripheral side effects. However, even though we see a reduction in peripheral side effects, when you combine these two drugs, you see an increase in some of the CNS side effects, particularly dyskinesias, dystonias, and hallucinations. So what are dyskinesias? Dyskinesias are essentially abnormal, involuntary movements. They tend to appear when the patient is on, and they are usually choreiform, meaning dance-like in their expression. Dyskinesias in the off state are more commonly dystonic and can be any of those that are listed above. Early on in levodopa therapy, patients may experience dyskinesias during the peak dose, shown here in red, in the therapy window. Peak dose dyskinesias usually start between 30 to 90 minutes after the dose of levodopa. Dyskinesias can take the form of dystonic posturing, which is more commonly occurring during the off period, but as the disease progresses, the dyskinesias can occur at any time. It's believed that many of these may be due to a cumulative dose effect, so the longer the patient's on some of these drugs, it's kind of a consequence of really long-term therapy. You'll see this is associated with levodopa therapy rather than direct agonists. Keep in mind, once levodopa was combined with carbidopa, the amount of levodopa required to produce a clinical benefit was greatly reduced. So therefore, we saw an increase in potency. So the dyskinesias became less common in the early stages of treatment. However, as the disease progresses and the dosing regimen changes, the possibility of developing dyskinesias increased. Approaches to managing troublesome dyskinesias often begin with adjusting the levodopa regimen and the use of adjuvant medications, including dopamine agonists. There are some complications to therapy. Patients with Parkinson's typically experience a smooth and even response to the early stages of levodopa treatment. However, as the disease kind of advances, the effect of levodopa begins to wear off several hours after some or even all of the doses, leaving patients aware that the duration of action of a dose is not being sustained. Motor fluctuations were alteration periods between being on, during which the patient experiences a positive response to medication, and being off, during which the patient experiences a reemergence of the Parkinson's symptoms, are typically suppressed in the on state. The reason motor fluctuations occur is not entirely clear, but current thinking holds that motor functions or motor fluctuations evolve as PD progresses because progressive degeneration of the nigrostriatal dopaminergic pathway reduces the ability of nerve terminals to store and release dopamine. As a result, not being able to store dopamine, the response to exogenous levodopa is kind of a bolus impact on postsynaptic dopamine receptors. This would reflect the short duration of the response. Levodopa has a relatively short half-life. Thus, if dopamine is not stored upon the conversion from levodopa, the duration of action will be quite short. There are, however, controlled release preparations that can be useful for the management of these dramatic fluctuations. Patients with motor fluctuations sometimes fail to turn on following a levodopa dose. This has been called a no-on response. In some cases, this is due to poor absorption of the oral dose of levodopa, which could be due to delayed gastric motility or administration of levodopa with a high-protein meal.